Jai Hind, a very good afternoon to everyone. At the outset, I would like to thank organizing team for giving me this opportunity to speak about full mouth rehabilitation at this forum. Full mouth rehabilitation is one such topic which is not only important from clinical aspect but also important from the clinical theory examination point of view. These are some of the questions that are picked up from previous RGHS question papers. They've asked FMR for 100 marks, 25 marks long essay, and also for short essay 10 marks. What is the goal of full mouth rehabilitation? It is to re-establish a state of functional as well as biological efficiency where stomatognathic system comprised of TMJ, muscles, teeth, and periodontal structure function together in synchronous harmony. Various classifications have been used for the ease of diagnosis and formulation of treatment plan. Most commonly used classification is given by Turner and Misirin in 1984. They classify full mouth cases into three categories. In category 1, excessive wear with loss of vertical dimension of occlusion. If you observe intraorally, there is excessive wear of the anterior teeth and few missing posterior teeth with unstable posterior occlusion. Closest peaking space of more than 1 mm and interocclusal distance of more than 6 mm is observed. Extraorally, there is some loss of facial contour or drooping of the corners of the mouth is seen. In category 2, there is excessive wear without loss of occlusal vertical dimension, but there is space available for the restorative material. If you observe intraorally, there is adequate posterior support with a long history of gradual wear. Occlusal vertical dimension is maintained by continuous eruption of the teeth and also by the elongation of alveolar process. Closest peaking space of 1 mm and interocclusal distance of 2 to 3 mm is observed. When the mandible is guided from maximum intercuspation to centric relation, there is anterior slide. In category 3, there is excessive wear without loss of occlusal vertical dimension, but there is limited space for their restoration. In these cases, posterior teeth exhibit minimal wear, but the anterior teeth show excessive gradual wear over a period of 25 years. Centric relation and centric occlusion is coincidental. Closest peaking space of 1 mm and interocclusal distance of 2 to 3 mm is observed. These are the cases that are most difficult to treat because of limited vertical space, and the space has to be created for the restorative material either by surgical crown lengthening or by orthodontic procedures. Let's see the etiology of wear. It could be because of attrition, abrasion, erosion, or abfraction. These are some of the etiological factors that causes tooth wear, like occlusal factors, bruxism, dietary habits, or underlying systemic medical condition, oral hygiene habits, or hyposalivation. Before proceeding into concepts of full mouth rehabilitation, let's understand what is vertical dimension. It is the mandible to maxilla relationship established by repetitive contracted length of elevator muscle. If you observe in this picture, there is wear of the teeth, but the vertical dimension of occlusion in accordance with the contracted length of the elevator muscle is maintained by the elongation of the alveolar process and passive eruption of the teeth. Can vertical dimension be altered? Many authors have given their opinion regarding the same. Syker and Silverman have concluded that as the teeth wear or become abraded, the alveolar bone elongate through the growth to maintain the original vertical dimension with the maintenance of same closest speaking space. Harry and Albert Cassis stated that increasing the vertical dimension places the muscles of mastication and temporomandibular joint under strain. Dawson said, increasing vertical dimension interferes with the optimum length of resting muscles, which serves as the stimulus to produce hypertonicity. Dawson also said that increasing vertical dimension should never be done for the following invalid reasons, like to relieve a TMD, to unload the TMJs, to restore lost vertical dimension in a severely worn occlusion, or to get rid of facial wrinkles. Let's see the concept of centric relation. All these years, there is change in concept of centric relation. In 1920, McCollum said that it is rearmost condylar position. Then Stewart came up with a rearmost, uppermost, and midmost condylar position. Then American Equilibration Society said that it is anterior and most superior position against the dorsal slope of the articular eminentia. If you observe GPT, from GPT-1 to GPT-8, there are various definitions for the centric relation. In GPT-9 and 10, they have given one definition of centric relation which is most acceptable. Let's understand the definition of centric relation. It's a maxillomandibular relationship which is independent of tooth contact, in which the condyles articulate in the anterior superior position against the posterior slopes of the articular eminence. In this position, the mandible is restricted to a pure rotary movement, and from this unstrained physiologic maxillomandibular relationship, the patient can make vertical, lateral, or protrusive movements. It is a clinically useful, repeatable reference position. If the mandible is in centric relation, the following five criteria should be fulfilled. First, the disc is properly aligned on both the condyles, and the condyle disc assembly are at the highest position against the slopes of the posterior slopes of the articular eminentia. The medial pole of each condyle disc assembly is braced by bone, and the inferior lateral pterygoid muscle have release contraction and are passive. And the TMJs can accept firm compressive loading with no sign of tenderness or tension, because there is no innervation or blood supply and it can bear the compressive loading. Why posterior position is not considered? Because of the presence of retrodiscal lamina, which is highly vascular and innervated. Coming to the methods of to guide the mandible into centric relation. First is chin point guidance method. Second is bilateral manipulation method, which is most commonly used method explained by Dawson. The other methods are unguided methods. Let's see what is muscle deprogramming. The muscles may change the position of the jaw whenever there is occlusal interferences. So to prevent the overloading of the interfering teeth and the constant repetition of this proprioceptive trigger receptors to the muscles causes them to become patterned to the deviated closure, and this memorized patterns of muscle activity is called muscle engram by Okeson, occlusal programming by Gishet, or proprioceptive engram system by Dawson. These muscle activity prevent the condyle to be seated into centric relation. So to allow the condyle into proper centric relation, we do muscle deprogramming. And it is based on reflective relaxation of the lower jaw when the posterior teeth are not permitted to engage. When the anterior jig is fabricated with increased vertical dimension, posterior teeth are not in contact, thereby there is no interferences contacting in the posterior teeth. This prevents and this allows the mandible to properly guide the condyle to centric relation. These are the various anterior deprogrammers that are most commonly used, like leaf gauge, Lucia jig, Pankey jig, or anterior bite stops. Once the mandible is guided to centric relation, we do load testing for the verification of centric relation by hinging the mandible into opening and closing movement. The load testing is done if there is any sign of tension or tenderness on loading. It is an absolute indication that the condyle on the affected side is not fully seated, or there must be some underlying intercapsular structural disorder. Please note, never accept a centric relation that has not been verified by load testing. If the load testing of the TMJ causes discomfort, always find out what is the underlying cause or the TMD and don't proceed with the case without treating the underlying cause. Coming to the occlusal approaches. There are two types of approach. The first is confirmative approach. The other one is reorganized approach. In confirmative approach, occlusion is reconstructed according to the patient's existing intercuspal position. It is adopted when small amount of restorative treatment is undertaken. For example, in your exams, you fabricate 3-unit FPD. In such cases, you don't record centric relation, you mount the cast in MICP. And this is called as confirmative approach. In reorganized approach, new occlusal scheme is established around centric relation position. The indications are loss of vertical dimension, repeated fracture or failure of restorations, severe bruxism, trauma from occlusion, presence of temporomandibular disorders or developmental anomalies. This reorganized approach restores the structural and functional integrity of dental arches that are compromised extensively could be because of pathologic occlusion. Coming to the review of literature of various occlusal concepts. In 1955, McCollum and Stewart gave gnathological concept. In 1915, Geisy introduced canine protected occlusion. In 1960, Stewart and Stellard proposed mutually protected occlusion. In 1960, Pankman-Schuller philosophy was given, and Obo Takayama came up with twin table and twin stage technique. Pankman-Schuller and Hobo philosophy are the most commonly used philosophies for rehabilitation, full mouth rehabilitation cases. I'll be explaining both the philosophy in detail. Coming to Pankman-Schuller philosophy. What are the goals? First, to establish a static coordinated occlusal contact of maximum number of teeth when the mandible is in centric relation. The anterior guidance should be in harmony with the lateral eccentric positions on the working side and disocclusion by the anterior guidance of all the posterior teeth in protrusion and also on the non-working side inclines in lateral excursions. Group function of the working side inclines in lateral excursion should be achieved. Coming to the sequence advocated by PMS philosophy, first the lower anterior teeth is rehabilitated, followed by the upper anterior teeth by establishing the anterior guidance and also harmonizing the anterior guidance with the condylar path. Then the lower posterior teeth occlusion is established or occlusal plane is established using BOPA or SOPA, which I'll be explaining in further slides. Then the posterior occlusion of the maxillary teeth is established using functionally generated path technique. Coming to the advantages of PMS philosophy. It is possible to diagnose for entire rehabilitation before a single tooth is prepared. It's a very well organized logical procedure and there is never need to prepare or rebuild more than 8 teeth at a time. It divides the entire rehabilitation into series of appointments without losing the patient's present vertical dimension, and all the posterior contours are programmed by and are in harmony with the condylar guidance and anterior guidance. The first step in PMS philosophy is restoring lower anterior teeth. And the starting point for occlusal scheme is incisal edge position, which is determined by the curvature of the incisal plane, the height of the incisal plane, and the horizontal position of the incisal edges. The height of the incisal plane is at the height of the juncture of upper and lower lip when the lip teeth are together. On a lateral cephalogram, it is usually positioned slightly above the incisal edge of the functional occlusal plane. While speaking, lower anterior teeth are displayed more, while smiling, upper anterior teeth are displayed. When lips are slightly parted, both upper and lower anterior teeth are equally displayed. The horizontal position of the lower incisal edge is determined by establishing stable holding contacts with the upper anterior teeth. Let's see the steps in customizing anterior guidance. In step 1, centric holding stops are established. And before proceeding with the correct anterior guidance, please remember to remove all the posterior interferences. The upper half of the labial contour can be determined fairly well on the cast by observing the alveolar contours. Then the lip closure path is examined in the patient's mouth. The incisal edge of the maxillary incisors should contact the inner vermilion border of the lower lip. This is done by asking the patient to pronounce F and V sounds. If required, refine the incisal edges. Establish long centric if required. If the patient complains of sudden hitting of the lower anterior teeth to the upper anterior teeth when the patient changes from the postural rest position to upright position. In step 7, establish the lingual contours in harmony with envelope of function in straight protrusive and lateral excursions. In step 8, evaluate S sounds, and the closest speaking position should produce no whistle or lisping. In step 9, evaluate the cingulum contours by asking the patient to pronounce T and D. Next, moving on to the 5 steps to harmonize anterior guidance. In step 1, establish the coordinated centric stops on all the palatal surface of the anterior teeth. In step 2, extend centric stops to long centric if required. In step 3, determine the incisal edge position of all the anterior teeth. In step 4, establish group function in straight protrusion. In step 5, establish ideal anterior stress distribution in lateral excursion. Dawson called this as dots in red and lines in blue. So for achieving optimum stability, comfort, function, the anterior teeth must be in harmony with neutral zone, lips, phonetics, centric lesion, and also envelope of function. Once the anterior guidance is determined and tested on the patient, it can be duplicated by use of customized anterior guide table. Coming to the determinants of occlusion, there are 2 types. One is fixed, the other one is variable, which I will not be going in detail. We made a mnemonym for the ease of your study. Next step in Pankman-Schuller philosophy, that is restoring the lower posterior teeth. 3 factors should be considered when you are restoring lower posterior teeth, that is plane of occlusion, location of each buccal cusp tip, position and contour of each lower fossa. The term plane of occlusion, more appropriately, it is the average curvature or imaginary surface that theoretically touches the incisal edges of the anterior teeth and the posterior occluding surface of the posterior teeth. In curve of P, the alignment of the mandibular posterior teeth is parallel with the arc of closure of the condylar axis. This allows disclusion of the posterior teeth in protrusive excursions. In curve of Wilson, there is inward inclination of the lower posterior teeth and outward inclination of the upper posterior teeth to resist the loading and also to help in masticatory function. Coming to various occlusal plane analyzers, most commonly used is BOPA and SOPA. These occlusal plane analyzers are based on spherical theory of occlusion. In Broderick's occlusal plane analyzer, which consists of bow compass and card index, these are the plastic cards which are mounted on the card index on the Ano articulator. The first step is to set the bow compass for 4-inch radius. Then anterior survey point is selected, usually at the disto-incisal surface of the canine. If canine is missing, wax pattern is done. If canine is attreated, it shifts to attreated incisal surface. The anterior survey point arc is scribed, a 4-inch arc is scribed on the card index. Then the posterior survey point is selected as the distobuccal cusp of the second molar. If second molar is missing, the condylar element, the anterior portion of the condylar element is taken as posterior survey point. The intersection of both the arcs is called as occlusal plane survey center. This is simplified occlusal plane analyzer, SOPA, which is used with Dinar articulators. The SOPA is preset with 4 inches from the condylar axis. The scriber is placed on the canine with a 4-inch radius and the pointer is placed on the arc. Then the scriber is moved from the canine to the posterior surfaces, and using this a wax index is made which will be used as guide in intraorally to establish the occlusal surface of the final restorative material. Let's see how the posterior occlusion is established. The posterior teeth in the lower arch can be accurately restored with cusp to fossa contact by determining the correct height and placement of buccal cusp, lingual cusp, fossa, and correct inclines of the fossa walls. The buccolingual position of the lower buccal cusp is positioned in such a way that the buccal cusp is placed in the central fossa of the maxillary teeth. This directs the stress or occlusal forces along the long axis of the teeth. The mesiodistal stability is achieved by placing the lower buccal cusp in the mesial fossa of the premolars. For molars, it could be either mesial or distal fossa depending on the non-interfering excursion. Next, the fabrication of fossa contour guide. First, the incisal pin is replaced with fossa contour pin. Then, the wax or self-cured resin is placed on the plastic incisal guide table. Then the upper member is moved to right lateral and left lateral excursion. Once the lateral path, excursive path, is achieved on the wax, the pin is opened and the handle for the fossa guide is placed on the pin. Chemical cured resin is mixed and it is placed to the handle and also to the carved path and allowed to set. This is the occlusal fossa guide. If you observe, the angle is steep. It is trimmed to ensure posterior disclusion. The fossa walls must be flatter than the lateral guidance. So this fossa guide angle is flattened on both the sides to achieve posterior disclusion. The occlusal fossa guide in the picture is showing how the occlusal anatomy is achieved using this guide on the metal restoration and also on the ceramic restoration. It should be held perpendicular to the restoration and the tip of the fossa guide should be contacting the fossa of the restoration and there should not be any interference on the fossa walls. Next is the last step in the Pankman-Schuller philosophy is restoring upper posterior teeth using functionally generated path model that incorporates all movements of the mandibular teeth against the maxillary teeth. This was explained by Meyer. For the ease of the technique, we have slightly modified this in our department. We have painted pattern resin on the reduced occlusal surface of the posterior provisional restorative material. Then the plaster was painted on the pattern resin. Stone core was fabricated as shown in the picture and it was mounted on the articulator. This functional core is a three-dimensional record of border pathways so that the articulator just serves as a device to maintain the relationship of the dies to the recorded path of movement of the lower teeth. Here if you observe, the wax pattern is done directly against the stone core. So using the functional model, there are three ways of using the functional model. The first one, you can wax against the anatomic model, then refine the occlusal inclines and check for interferences against the functional model or stone core. The second option is you can complete the castings against the anatomic model, then adjust the metal or porcelain occlusal surfaces against the stone core. The third is directly wax against the stone core as shown in the previous picture. This picture shows how the wax is carved to attain group function. Here, the lingual inclines should be in contact with the stone core to achieve group function of the buccal cusp. Then, the balancing side disclusion can be achieved by keeping the balancing inclines out of contact to the stone core. In this picture, you can show how to achieve posterior disclusion by keeping only the centric stops in contact with the functional core. So this, I repeat, the group function is achieved by lingual inclines of the upper buccal cusp in contact with the functional core. Then balancing side disclusion is achieved by keeping the balancing inclines out of contact. Then the posterior disclusion is achieved by keeping the centric stops in contact with the functional core. This is a case treated in our department using Pankman-Schuller philosophy. The guide Lucia jig. The jig was fabricated. Then the record basis, that is the centriculation bite registration, was done with a slight increase in vertical dimension. Then the anterior mock-up was done and posterior occlusal plane was established using BUPA. The mock-up was done, then the anterior guidance was customized and it was recorded, followed by anterior bistral. The anterior teeth was temporarily cemented. Then the posterior metal trine was done of the mandibular, followed by upper posterior metal trine, and recording of the upper posterior teeth using functionally generated path technique. This is the final pictures of this case. You can see the static coordinated contacts in centriculation and disocclusion in the protrusion and canine guided occlusion on the lateral excursion. Let's see the criteria for success in full mouth rehabilitation cases. It can be tested by doing load testing, clench testing, grinding testing, or negative, or Fremitest test should all be negative. Whenever there is load testing, there should not be any sign of tension or tenderness in the TMJ. And the restoration should be stable. When you are following up the case, there should not be any wear or chipping of the restorations. The patient should be comfortable with the lips, face, and teeth with no speech concerns of the patient. Aesthetically, the overall appearance should be good and patient should be satisfied. Let's move on to Hobo's philosophy. Gnathological concepts primarily focused on condyle path. McCollum and Stewart said that anterior guidance was independent of condyle path. To verify whether the condylar guidance and anterior guidance were independent factors, Hobo and Takayama measured the lateral condylar path in 10 patients using electronic mandibular recording device. The measurements were recorded under two test conditions, one with tooth contact or without clutch, and the second one non-tooth contact or with a clutch placement. The results demonstrated that working side condylar path changed remarkably while the non-working side condylar path did not reveal noticeable change. So with this, it was observed that condylar path was affected by anterior guidance. Then they concluded that anterior guidance and condylar guidance were dependent, not independent. Anterior guidance, though it only ranges from 2 to 6 mm, it greatly influences occlusion. In healthy patients, anterior guidance is approximately 5 degrees steeper than the condylar path in the sagittal plane. And this steepness, because of this steepness of the anterior guidance, the downward movement of the mandible creates posterior disclusion. So coming to the determinants of disclusion, there are three factors. One is angle of hinge of rotation, cusp factor, and incisal path. Let's study in detail. What is this angle of hinge of rotation? If you observe in this picture, whenever the mandible rotates around the intercondylar axis in protrusion during eccentric movements, the anterior guidance is steeper than the condylar path. If you observe this picture, the anterior guidance is steeper compared to condylar path. And the factor that compensates for the difference in this steepness is called the angle of hinge rotation. Takayama and Hobo analyzed disclusion relative to the angle of hinge rotation by using kinematic formulae. And they came up with the angle of hinge rotation contributed to around 0.2 mm of disclusion in protrusion and 0.5 mm in working side and non-working side excursions. The actual disclusion during protrusion and lateral movement on the working side differ from the angle of hinge rotation. So this leaves a residual amount of disocclusion that was unaccounted, and later they found out that the 0.9 mm on the protrusive movement and 0.5 mm on the non-working side was contributed by cusp shape factor. Let's see the mechanism of disclusion. In the first scenario, if you observe the condylar path, the cusp factor or the cusp component and the anterior guidance is parallel to each other. Hence, there is no disclusion, and this is a case of balanced occlusion. In the second scenario, if you observe, the anterior guidance is steeper compared to cusp component and condylar path. So this leads to disclusion in the posterior teeth because of the hinge of rotation, as I've already explained, and also anterior guide component, that is because of the steep anterior guidance compared to condylar path. In this scenario, the disocclusion is seen because of the cusp shape component. If you observe here, the cusp angle is shallower compared to condylar path and anterior guidance, which are parallel to each other. In the last scenario, if you observe, anterior guidance is steeper compared to condylar path and cusp factor, and the cusp factor is shallower. This is typically seen in healthy patients, and this leads to posterior disclusion with wide separation of the posterior teeth. Coming to twin table technique, there are two incisal guide tables are prepared, one without disclusion, the other one with disclusion. Incisal table, guide table without disclusion. In this, the anterior segment is made removable by using dowel pins. Why? To avoid the obstruction or any obstacle while doing the wax pattern or establishing the occlusal contour of the posterior teeth. The anterior segment is removed. If you observe this picture, once you remove the anterior segment, you have to place carbon occlusal paper between the upper and lower teeth and do the excursive movement. So this will show the if any occlusal interference is present, you have to remove the occlusal interferences. Then if there is any deficiency on the occlusal surface, please build up with the wax so that both the upper and lower teeth glide smoothly and interdigitate properly by establishing balanced occlusion. So you have fabricated incisal guide table without disclusion. So you're not going to place any anterior segment here, and the posterior contacts should have smooth gliding movements just like balanced occlusion in all the eccentric movements. Coming to incisal guide table with disclusion. In this, first you have to place 3 mm thick plastic spacer behind the condylar in the condylar fossa behind the condyles to approximate 3 mm protrusion on either side. Then vinyl sheet of 1.1 mm thick is placed on the tip of the mesiobuccal cusp of right and left mandibular first molar that creates average disclusion during protrusive movement. Coming to disclusion in lateral movements, as shown in the picture, vinyl sheet of 0.1 mm is placed on the tip of the mesiobuccal cusp of mandibular first molar on non-working side and 0.5 mm on the working side. So this is the picture showing the lateral movement, protrusive and the lateral movement. Resin cones are fabricated or made. Then after this, the resin cones are joined by using chemically cured acrylic resin to achieve 3 mm disclusion in protrusive movement and 1.1 mm disclusion in the non-working side and 0.5 mm on the working side. So this is the picture showing incisal guide table without disclusion and incisal table with disclusion. So after completion of the posterior waxing, the incisal guide table with disclusion is attached on the articulator and the anterior segment is replaced. The anterior, after repositioning, the melted wax is placed over the lingual surface of the anterior teeth. Then articulator is closed and moved through all the border movements to form the anterior guidance. That's about twin table technique. Let's move on to twin stage technique. Here, Hobo has given two conditions. Let me explain in detail about that. In condition 1, that is without anterior teeth, Hobo has given condylar settings and anterior guide table settings as shown in the picture. The sagittal condylar path is kept at 25° and Bennett angle at 15°, and sagittal inclination of the anterior guide table at 25° and lateral wing angle at 10°. With these settings, you have to remove the anterior segment and establish the balancing contacts on the posterior teeth, just similar to the twin table technique. Once this is done, you move on to condition 2, that is with anterior teeth. The settings include 40° on the sagittal condylar path inclination, and Bennett angle remains same, that is 15°, and sagittal inclination of the anterior guide table is kept at 45°, that is steeper than the condition 1. Then lateral wing angle at 20°, again 5° steeper. With this, you have to position the anterior segment. Because of the steep anterior guidance, you get posterior disclusion as shown in the picture. So this is a case treated in our department using Hobo's twin stage technique. You can observe the posterior disclusion and canine guided occlusion in lateral excursions. Coming to digital technology in full mouth rehabilitation using intraoral scanners, CAD/CAM, 3D printing. This was a case treated in our department where first the intraoral scanning was done. Then the anterior teeth was designed using ExoCAD software. And the virtual mounting was done using Artex articulator from the library. Once the contacts, protrusive and lateral contacts were observed and the disclusion in the protrusion was observed, it was approved and the restorations were milled. So we planned for zirconia restorations in the anterior for the anterior teeth, that is layered zirconia restorations for the anterior teeth. Then it was checked in the patient mouth and it was proceeded for the posterior designing of the restoration, which was PFM. The metal train was done. Then the restorations were placed in the mouth to check for the occlusal contacts. So that's about full mouth rehabilitation. Thank you for your patient hearing. Jai Hind.